So we've been talking the past couple weeks about different issues with the body and how, especially last week with skin integrity, and how important it is that we have good nutrition. It's vital for life, to just maintain good life, and it's also helpful when we have something that goes wrong and we need our body to repair itself. Poor nutrition can definitely decrease our level of wellness, and it is a very vital component of nursing. I feel like it is something that as nurses we look over sometimes because it's not that big critical thinking piece, and it could include a lot of education, so it's easy to overlook. But we definitely have to remember how important nutrition is and how it affects our patients. So the definition of nutrition is it's simply the intake and use of nutrients by the body. Nutrition plays a big part in growth and development. As soon as we're born, those infants, it helps with our tissue maintenance and our repair, our cellular metabolism, and even our organ function. So our body needs an adequate supply of nutrients in order for our cells to function properly. And we also need it just to maintain our body's processes and to recover from injury or illness. It's imperative, like I said, that we have a knowledge of nutrition because we provide holistic care. So we are a lot of different things in one. We know that in some illnesses, such as type 1 diabetes or mild hypertension, diet therapy is often the primary means of controlling the disease. So if we're going to be educators for our patients and we're going to help them with disease modification and prevention, then we need to know how nutrition affects these disease processes. We also have to understand that for many people, different ethnic backgrounds, cultural backgrounds, food can be very symbolic. It's a part of a lot of different ceremonies, social gatherings, holidays, religion, and celebration. All right, so looking towards Healthy People 2030. So we've talked about Healthy People since we started this class. The new initiative that we're looking at right now is for 2030. These are guidelines that the U.S. Health Department of Health and Human Services sets up as goals, what they want society as a whole to accomplish. So the development of our Healthy People 2030 includes establishing frameworks for vision of their company, of what Healthy People stand for, what their mission is, what their principles are, what their plan of actions are, and what goals they want to achieve. And they also look to identify new objectives. They promote health and well-being. They prevent disease. They believe that all of those together help encompass physical, mental, and social health and dimensions. It's investing to achieve the full potential of health and well-being for all benefits to society. All right. So this is just an overview of our how we intake nutrition, how we start at the top with our teeth and our mouth and our tongue. We use that to take food in, to chew it up, mixes with our salivary glands. Down our pharynx, we have our esophagus, our diaphragm, and then there's the whole, your gallbladder, your liver, and your stomach. So just kind of a refresher there from anatomy and physiology. So these are the parts of our gastrointestinal tract. So we have our mouth, which has obviously our mouth and saliva. We have our pharynx, our esophagus. Our esophagus is responsible for producing mucus to help get down our food. We have our stomach, so we have those cheap cells, those parietal cells, that hydrochloric acid. They all work together to help us digest food. And then our small intestines, so our duodenum, jejunum, and our ileum. And then the parts of our large intestine is our cecum, our ascending colon, our transverse colon, our descending colon, our sigmoid colon, and then finally our anus. So this should all be a refresher from anatomy and physiology. So some basic terms that we're going to be talking about tonight is ingestion. So this is the act of chewing or just swallowing food. Digestion is that process by which our foods are going to be broken down into smaller and smaller parts, so it can go into our intestines. And then absorption, this is when our nutrients pass through the intestinal walls into our body circulation from the food that we have eaten. So we're going to talk a little bit about some nutrients that our body needs. So we have 6 classes of nutrients. So I have them broken down into categories. So we have nutrients that our body needs to supply energy, and then nutrients that regulate our body's processes. So the nutrients that supply energy, those are going to be your carbohydrates, your proteins, your lipids. And our nutrients that regulate our body processes, that's going to be our vitamins, our minerals, and our water. So we're going to talk about essential nutrients and non-essential nutrients. So essential units are not synthesized in the body or are made in insufficient amounts. So either we don't make them or we make them but not in high enough amount that it's going to make a difference. Essential nutrients must be provided in our diet or through supplementation. They also provide energy for our body. They can help regulate different processes within our body, and they really help our cells to be able to grow. And they also can repair injured tissue. So these are our proteins, our lipids, our minerals, and our water. Oops, this should be down here. Sorry. All right, so nutrients that provide energy for cellular metabolism, tissue maintenance and repair, organ function, growth and development, and physical activity. We need nutrients we need a proper balance of nutrients through our diet and fluid intake, with consideration of energy intake and requirements, so that we can have what we consider an adequate nutritional status. So again, just to recap, our nutrients that supply energy, that's your carbohydrates, your protein, and your lipids. Water is one of the most basic of all nutrients, but it's extremely crucial for all of our body fluid and our cellular functions. And then those nutrients that regulate body processes, vitamins, minerals, and water. All right, so My Plate, I'm sure you guys have seen this before. This is an initiative that was developed by the Dietary Guidelines for Americans so that they could help Americans make better food choices and encourage healthy eating patterns from across their lifespan, from the time they were born and old enough to eat table food up until you're an elderly adult. They decided to use this image of the plate because they thought that it was a familiar image for most people, and it was the place setting for every meal that most people have. It is designed to remind us to eat healthfully, and it is designed to illustrate the 5 food groups that we usually use during mealtime, to visualize them. So our fruits, our grains, our vegetables, our protein, and our dairy. So the thought process behind this is that you will divide your plate into portions. At every meal, we should have a serving of fruit, some grains, some protein and vegetables, and some dairy, but in certain healthy amounts. So obviously, if you look on this plate, vegetables are the biggest portion. So you would have more vegetables, and followed by your grains, followed by your protein, and then your fruits, and then a small amount of dairy. So the recommendations are to balance calories by encouraging patients to enjoy food but eat less and avoid oversized portions. And it also breaks down how to read nutrition labels. So that's the initiative. And you can go to choosemyplate.gov, and they have a lot of information there. All right, carbohydrates. So carbohydrates provide most of our body's energy and fiber. Each gram of carbs produces 4 calories. Carbohydrates help provide glucose for our body, which will burn completely and efficiently without end products that need to be excreted. We can get carbohydrates in whole grain breads, baked potatoes, brown rice, and other plant foods. You will hear them interchangeably also called starches or sugars, but it's all the same thing. Organic compounds are composed of carbon, hydrogen, and oxygen, and carbohydrates do serve as the structural framework of plants. Lactose is the only animal source of carbohydrates. Carbohydrates are the most abundant and the least expensive source of calories in the world. And like I said, they are classified as simple or complex sugars or starches. Protein. Protein helps contribute to our body's growth, also maintenance and repair of body tissues. So when we talked last week about our patients that had skin issues, we said that it's important that they have a good amount of protein in their diet because it helps repair things, repair your skin, repair injuries. Each gram of protein produces 4 calories. Sources of complete protein would be beef, whole milk, and poultry. Protein is required for the formation of all body structures. They are labeled high quality or incomplete. So they're complete high quality, or incomplete low quality. They determine how they're labeled based on the amino acid composition of the protein. Animal proteins are considered complete. Plant proteins are considered incomplete. The only exception is soy, which is a plant protein that is considered a complete protein. So that's the only exception. Protein in our tissues are considered to be in a constant state of flux. They're always changing. So the tissues are always being broken down through catabolism, and then they're being replaced by anabolism. And this process is constantly going. 24 hours a day. The recommended daily allowance for adults is 0.8 grams per kilogram of body weight. That's how much you should take in protein. And then it should encompass 10 to 35% of your total calorie intake. So fats, our fats help provide energy and vitamins. No more than 10% of our caloric intake per day should be from fat. I think that's where a lot of people have issues. It takes, in order to be successful with dieting and really watch what you eat, you really have to learn how to read food labels. And for a lot of patients, this is a problem. Unless you work in the healthcare field or you have been involved in some kind of health maintenance program, some people really don't know how. They can read for calories and serving sizes, but they don't really know a lot of all the other stuff on the labels. So that's why education is so important for these patients. So no more than 10% of their caloric intake a day. Each gram produces 9 calories. Healthy sources include olive oil, salmon, and egg yolks. And then these fats are composed of carbon, hydrogen, and oxygen. And then 95% of the lipids that we find in our diet are triglycerides, which are not good for us. So our fats contain a mixture of fatty acids. So we have saturated fats, which are not good. These help raise our cholesterol levels, which we don't want. And then we have unsaturated fats, which lower our cholesterol levels. So obviously we want to have a higher level of unsaturated fats in our diet than saturated. Most animal fats are saturated and most vegetable fats are unsaturated, which gives proof to to the vegan diet and why a vegan diet is so helpful with reducing cholesterol. And then fat digestion occurs largely in the small intestine. So some dietary guidelines for when we're teaching our patients, we should educate them that they need to have a diet that is balanced. So it should include fruits, it should include vegetables, whole grains, and healthy fats. Total fat intake should be 20 to 35% of our calories, with most fats coming from polysaturated and monosaturated fats. We want our patients to eat a moderate number of lean meats, poultry, and eggs. Moderation. We want to educate them to reduce the amount of sugar intake. We want to encourage physical activity, so they should be getting daily exercise. We recommend 30 to 45 minutes a day, 3 to 5 days a week. And then we want to encourage our patients to prepare foods with little salt and avoid purchasing processed foods or foods that are high in sodium. So processed foods, so things in boxes, frozen meals, things like that, they're all packed high with salt. All right, so we're going to talk a little bit about vitamins. So we said that essential nutrients are needed in small amounts for metabolic function. So we have two forms of vitamins. We have water-soluble vitamins and fat-soluble vitamins. Vitamins are necessary in order for metabolic things to take place in our body. We need they're organic compounds needed by the body, but in small amounts. Most are active in the form of coenzymes. Together with enzymes, they facilitate a lot of chemical reactions in the body. They don't provide energy, but are needed for metabolism of carbohydrates, proteins, and fats. So our fat-soluble vitamins are A, D, E, and K, and our water-soluble vitamins are vitamin C, which is also called absorbic acid, and B complex, which is absorbic acid, thiamine, riboflavin, niacin, pyridoxine, biotin, folate, and cobalamin, which is B12. Vitamins are going to be absorbed through the intestinal wall, and they're going to be taken directly into our bloodstream. Vitamins, I put down here in the notes for you guys, vitamin A affects our visual acuity. It helps with our skin. It helps with our mucous membranes, and it helps with our immune function. And then we know vitamin D is going to provide that calcium and phosphorus metabolism, and it's going to stimulate calcium absorption. Vitamin E is an oxidant that protects vitamin A, so you usually see them taken together. And then we know vitamin K helps with the synthesis of certain proteins that are necessary for our bodies to adequately clot our blood. All right, so these are our water-soluble vitamins. Again, the B complexes, we just read all those off. Vitamin C, so vitamin C functions also as a coenzyme, and they are pretty easy to absorb, no issues. Excesses amounts of vitamin C are usually excreted. Usually a low risk for toxicity from excess intake. So if we take too much and our body doesn't need it, it gets rid of it. But it only stores a minimum amount. So deficiencies in vitamin C can develop much more quickly. So that's why we recommend that our patients take in daily amounts of vitamin C, either through diet or through supplementation. So those fat-soluble vitamins A, D, E, and K, they help with structural and regulatory processes in the body. They are going to be taken in and absorbed through the lymphatic system, and they're going to be stored in our fatty tissues. In order for them to be transported through our blood after we take them in, they have to be attached to the protein. They don't go on their own. And the thing about these vitamins is that the excess is stored. So if whatever we don't use, our body holds on to, mostly in our liver and in our fat tissue, which means that we're at a greater risk of toxicity from taking in too much. And because we are able to store it, our deficiencies take longer to present. So the complete opposite of that vitamin C. So excessive intake can happen, particularly with vitamins A and vitamin D. So what are some factors that affect nutrition? So we know religious and cultural practices can definitely affect our intake and the type of foods that we eat because it's how we were raised. It's an important part of our culture. It's how we recognize certain things and how we celebrate. So we have to, when we're making recommendations to our patients, we have to take those things into consideration because there might be things that they're not willing to budge on because it's part of their culture. We have to think about financial issues. So we do know that healthier foods do tend to be a little bit more expensive. So if a person is having financial issues, they've had a change in their income, or they've lost their job, or they just are in a lower income bracket, they might not always be able to afford those foods that are higher in protein with vitamins and minerals. We have to think about our appetite. So if our appetite changes for any reason, we're not going to have adequate nutrition. So sometimes our appetite obviously changes if we're not feeling well, if we're sick. It can also change as a result of different medications that we take that make you nauseated or that just decrease your appetite. A lot of the stimulants that we give for ADHD have that effect. They cause a lot of children, they monitor them very closely for weight loss and lack of growth because it really has an impact on their appetite. If we're in pain, sometimes we don't want to eat. If patients are depressed, and if they are in an unpleasant environmental area with negative stimuli, then obviously that's going to have an effect on your nutrition. Negative experiences with certain foods or familiarity with foods with clients. So a good example of this would be when we talk to our chemo patients, they're at a high risk because of their treatments for vomiting, having diarrhea, having a lot of stomach issues. So we really do a lot of education with them and tell them that when they're taking chemo, that they should probably avoid some of their most favorite foods, not all of their favorite foods, but some of their most favorite, because what happens is if they get nauseated and they wind up vomiting, say they love crab cakes and they had a crab cake. Well, they had their chemotherapy and now they're going through that period where they're really nauseated. And if they vomit, they can develop what's called a learned aversion. So a learned aversion is when you eat something and you throw up and then you don't ever want to eat that food again. So we do a lot of education with our oncology patients about that. So that would be a negative experience. Environmental factors such as sedentary lifestyles, work schedules, and then access to healthy foods can contribute to obesity. So we know not getting up and not exercising, not having time to exercise because you're working too much or you're in school. Disease and illness can affect the functional ability to be able to prepare and eat food. So if you're sick or you have some kind of impaired mobility, maybe you can't ambulate in your house the way you used to, or you can't get your walker into the kitchen, or you can't stand for long periods of time and you can't prepare your food. That can be an issue. And then medications can alter the taste and appetite and can interfere with absorption of certain nutrients. So chemotherapy is another big type of medicine that will alter your taste and your appetite for a long period of time. And then we know that as we get older, our age is going to affect our nutritional requirements because as we get older, we start to eat less. So we can have different developmental factors, gender. Men have more of a caloric intake because they're usually have more of a higher muscle mass than women. Our health conditions, our general state of health can have an impact on our nutritional status. Anyone who's suffering with alcohol abuse, it can alter their body's ability to take in and hold on to nutrients. They lose a lot of nutrients. So they have a greater need for vitamin B. We said different medications, and then mega doses of nutrient supplements. So Some people take a lot of different supplements for many different things. And what can happen is they can all interact with each other and have drug-like effects that can interact with food and medication. All right, so developmental factors. So our infants, their birth weight triples by age 1. Their nutrient needs are much greater during this year than in any other time. This is a new period for a lot of changes that occur in 1 year. We're going from formula to introducing food. So we're introducing foods, one at a time over the span of a week. You start with vegetables and then you move to fruits and then you introduce a new one every 3 to 5 days. We're monitoring for allergies. When we get into the adolescent period, we know that this is a period of rapid physical growth. There's also emotional growth. They become more social, and we see a lot of sexual maturation. They're going to go through growth spurts in their mid-teens. Their habits may be affected by making poor food choices. Maybe they play a lot of sports, or they're really busy, or they get up early for school. They may skip breakfast. This is also an age where we see, especially girls, develop eating disorders. So we have to look for anorexia. Are they taking diet pills? Are they fasting? Fasting is not something that's recommended for children. Are they over-exercising? Are they not exercising? So there's a lot of different issues in that adolescent time. And then our adults. So as adults, we see a decline in our basal metabolic rate with each decade. Every decade older that you are, it becomes a lot harder to lose weight because that basal metabolic rate slows down. We become more aware of the preventative role of exercise or the pressures of work and family that can lead to us not participating in physical activity. Our nutritional needs will start to level off as we approach that older adult, like in our 50s. We require fewer calories than we normally used to. And then we're going to see weight gain changes if changes in our caloric intake are not made. So if we still keep eating like we are used to eating, but then we have that decline in our basal metabolic rate, then we're going to start to gain weight, which is something that a lot of people complain of in late 30s or early 40s into your 50s. So then we have our older adults. Well, their expenditure decreases due to the decreases in their basal metabolic rate in combination with a lack of physical activity. And then we're going to see a loss of lean body mass. As they get older, they may have issues with their teeth. They might lose teeth, which makes chewing more difficult. Peristalsis slows down, which can cause constipation. So they might feel full, so they might not eat a lot. We do lose that taste between sweet and salty as we get older. So food might taste different. So they might not eat as much because it doesn't have the taste that it used to. And then we know that that sensation of thirst starts to decrease. That drive that tells us that we're thirsty, they don't have that mechanism anymore. So dehydration and fluid status becomes an issue for our older adults. And then for pregnancy and lactating, well, we know when we're pregnant, our nutrient needs increase because we're eating for not just ourselves, but a whole nother person. We see a lot of GI changes. We can see nausea in the beginning, sometimes throughout, vomiting, heartburn, constipation, and then those caloric needs are higher after you're pregnant, if you continue to lactate and you're breastfeeding. So gender differences. So our men differ from women in their nutrient requirements, mainly due to the differences in body composition and reproductive function. So men have a larger muscle mass, which translates into them needing a higher caloric intake, and they also need higher protein requirements. Women have proportionately more adipose tissue. And then women of childbearing age have higher iron requirements related to menstruation because they're losing that blood every single month. So they require more iron in their diet. And then our state of health. So our nutrition requirements change whenever we are sick or we have some type of an illness. So an example would be whenever our body is, when we're sick and we have a fever, this is going to increase the need for calories and water. For trauma, so any kind of major surgery, burns, crush injuries, they affect the use of how our body uses nutrients. And then our nutrient requirements increase because they're going to want to replenish what we've lost through our illness, or they're trying to preserve and hold on to them. And then, of course, we have those chronic disorders. So our patients with diabetes, cancer, any kind of GI disorder, which affects the way we get our nutrients and how we break it down, heart disease, hypertension, renal disease. They alter our nutrient requirements by influencing our nutrients intake, either the way we intake them, the way we digest them, the way we absorb them, our metabolism, our utilization, and our excretion. So we know excretion has to do with our kidneys. So any kind of GI issues, they could alter the way we digest things and how we absorb them. And then metabolism, that could also, any kind of issue with your liver can affect that. And then our mental health problems. So it might not be a physical problem. So depression, confusion. So if you're depressed, you might not have any type of appetite at all. Or if you're confused, or if you have some type of dementia, you can forget to eat, or you have a lack of motivation. All of these things can contribute to malnutrition. And then alcohol abuse. So alcohol alters our body's ability to be able to process and hold on to nutrients. Alcohol has an effect with the intestinal mucosa, which interferes with the body's ability to be able to absorb all of those nutrients. Requirements increase as the efficiency of the absorption of the ability to absorb decreases. The need for vitamin B increases because vitamin B is used to metabolize alcohol. So this is why they always have such a deficit of vitamin B. It affects metabolism by impairing our ability to be able to store nutrients, increasing our nutrient catabolism, and increasing our nutrient excretion. Abuse will result in liver damage, and it has a profound effect on the body's nutrient metabolism and requirements. So almost all the time in the clinical setting, if you have someone who's coming in that does abuse alcohol, or if that's why they're there, they will all the time, you will just be giving them vitamin replacements all day long, usually by IV. It's one of the, along with monitoring for alcohol withdrawal, it's one of the biggest things that we do for our patients because they're so, their bodies hardly have any nutrients at all, and they're very malnourished. All right, so we know medications can also have an effect on our appetite and our nutrient requirements. So some medications, our nutrient absorption can be altered by if they change the pH of our GI tract. Some medications increase our GI motility. So if our motility is increased, we aren't really able to hold on to those nutrients. They're just coming out every time we go to the bathroom. These certain medications can damage the intestinal mucosa. And then sometimes they can bind with nutrients and make them unavailable for our body. Nutrient metabolism can also be altered when certain medications act as an antagonist to certain nutrients. They can alter the enzyme systems that ultimately metabolize all of our nutrients, and they can alter nutrient degradation. All right, so we said mega doses of vitamins. So some nutrients will compete against each other for absorption. An excess of one nutrient can actually lead to a deficiency or an increased requirement of another. Our dietary supplements have drug-like effects. They can interact with other supplements, and they can interact with food and medication. And then we know how important it is to ask our patients if they're using those a variety of different herbs, vitamins, minerals, because this can impact the plan of care and it can impact any medications that we want to prescribe for them. And a good example that your book says is that some patients, a lot of patients will take ginkgo biloba, which is an herbal supplement. And they may actually be taking aspirin too for like a headache, but the two of them combined together will increase the risk of bleeding. So this is how important it is for us to know what they take on a regular basis, because most people don't consider vitamins or minerals or other type of supplements medications. So you have to be pretty specific. So this is the nursing process: assessing, analyzing, planning, implementing, and evaluating. So with assessing, we are gathering all of our patients' data, all that important information. We're analyzing all the issues. So we're identifying problems, we're formulating nursing diagnoses. Then we're going to start to plan. So we're going to look at all of our diagnoses, figure out which one is our priority. We're going to write a care plan because we want to be able to meet the patient goals. Implementing is when we start to carry out that care plan that we wrote, and then evaluating is when we go back and look at all of our information to see if our goals were successful. And then if not, then we start all over again, the same process. So when we do a nutritional assessment on our patients, there's a couple different components. So history taking, again, is always that first. So we want to know about their dietary history. So how do they normally eat every day? Tell me in a day what your diet looks like. What do you have for breakfast, lunch, or dinner? They may think that they have a good diet, but once they start talking to you and they tell you that they had, they might say, I eat a lot of vegetables. I eat a lot of fruits. Well, tell me what you had for lunch today. Well, I had deep fried cauliflower and chocolate covered strawberries. So they might think that they're healthy because they're eating them, but they're chocolate covered and they're deep fried. So not necessarily healthy. So really have them explain to you what a day in their diet looks like. We want to know about any medical issues that they've had, particularly any problems that could be affecting any nutrient absorptions. So do they have any stomach issues? Do they have GI bleeds? Have they had any type of surgery? Any maybe gastric bypass, anything like that? What's their socioeconomic data? This could give you some insight into whether or not they're struggling to even get proper nutrition. Then we want to take physical assessments. So we're going to be looking at something called anthropometric data and clinical data. We're going to talk a little bit more about that. We're going to look at laboratory data. So we're going to look at, we want to pull certain labs that will tell us our patient's protein status. We're going to look at certain vitamins, minerals, and trace elements in the body. And then one of the most important things is that nurses who role model good health behaviors are more effective teachers. And this is extremely true. Very, very true. We can't educate our patients to do certain things if we ourselves aren't doing it in our own lives. So we have to be good role models. So that nutritional screening, again, this is a very important part of the nursing assessment. We're going to be looking for cues that are associated with nutrition problems to try and determine if a person is malnourished or maybe they're at risk for malnutrition and they might not even know it. So we can do something called the mini nutritional assessment tool. You can see this on page 1296 of your book. This helps detect older adults that could be at risk for malnutrition. It looks at changes in their albumin level and it correlates with their BMI. We can have patients do that 24-hour recall method where they tell you what they've eaten over the last 24 hours, break it down meal by meal. We can encourage patients to, if this is more on an outpatient setting and they're going to be following back up with us, we could have them do a food diary. So get yourself a little journal, write down every day exactly what you're having, how much you're having, or you can even do calorie count. So if you've worked with them and they know how to read labels and stuff like that, or they have an app on their phone, there's a lot of apps on your phone. MyFitnessPal is a good one. You can just type the food in, and if you measure it and you know how much you've eaten, it'll count up all your calories for you. You can do a food frequency record. So this is an average number of times certain foods or food groups are consumed in a given period of time. So when we talk about, excuse me, in detail, that diet history, so we want to know how many meals are you having per day? So do you eat just once a day? Do you eat 3 times a day? Do you eat 6 times a day? Maybe they're little meals, maybe they're not, maybe they're full meals. This can tell you a lot about their current nutrition status. We want to know, do they have any food allergies? Sometimes there could be allergies in their diet that they do recognize or that they don't recognize that can cause a variety of different health issues. We want to know, what does their fluid intake look like each day? How much are they drinking? What type of fluid are they consuming? Are they consuming a lot of water? Do they have a lot of caffeinated beverages, a lot of soda, a lot of sugar, sugary drinks, beer, alcohol, what wine, what are they drinking? We want to know, excuse me, what their food preferences are. So what do they like to eat versus what do they not like to eat? How much do they usually eat at each setting? Do they feel like they overeat? Do they feel like they don't eat enough? Do they have any issues with swallowing or chewing? If they have any issues with swallowing or chewing, this could obviously lead to some type of nutritional deficit if they aren't able to take their food in. So with patients that have had strokes, so if a patient just has a stroke, last week, they might not have a nutritional deficit yet, but this is a good example of how that patient would be at risk for developing a nutritional deficit, because if, depending on how bad their stroke was, they might have some dysphagia now, they might not be able to chew or swallow like they normally used to. Excuse me. So food preparation. So who prepares the food? Do they prepare the food? Can they prepare their food? Do they have any type of functional disability where they can't stand for long periods of time? Do they ambulate with a walker? Do they not have good use of their hands? Have they had a stroke and they have lost, the whole, the ability to use their whole left side and they were left-handed? This could impact whether or not they're going to be able to prepare food for themselves at home, especially if they live alone. Then we want to think about, do they prepare their food with, so if someone says, oh, I eat a lot of vegetables, I have broccoli and cauliflower and Brussels sprouts all the time, well, then they coat them with butter, so not necessarily healthy. So how are they cooking their food? Deep frying in the air fryer, what do they use? Purchasing practices. So where are they getting their food from? Do they shop the outer perimeter of the grocery store, all those healthy fruits and vegetables and whole foods, or are they shopping towards the middle and they get a lot of processed foods? How is their appetite? Do they have a history of any type of indigestion, heartburn, or gas? This can all affect your ability to take in food and get the proper nutrition. What is their elimination patterns? Are they constipated? Are they going to the bathroom too often? Do they have diarrhea? And then again, you want to look at those religious, cultural food preference and restrictions that we talked about. Assess, do a good medication reconciliation. Look at those medications they take every day. See if any of those medications could be contributing to any type of nutrition deficit. And then we want to look at their activity level. So how sedentary or active are they? So medical and socioeconomic data. So we want to look at their medical data. So what is the current illness that they're here for now? And we also want to look at their past medical history. That can tell you a lot about things that you have to be on the lookout for. What kind of surgical history have they had? Have they had any bariatric surgery? Sometimes it can make it hard for them to absorb nutrients depending on what type of surgery they've had. Do they have a history, past or current use of any drug history, drug dependent or drug abuse? Do they have any issues with the ability to chew and swallow, including any conditions in their mouth? Do they have any missing teeth? With our cancer patients, we always have to think about their treatment. So not only does it do these medications make them nauseated and it causes them to lose their appetite? But after a certain number of days of having the chemo, they get these really horrific sores inside their mouth. They're like huge ulcers. Some of them can be as big as quarters. They get them all inside their mouth. They get them all down the back of their throat. They can't eat. So that would definitely be a condition of the mouth. Sometimes they also get like thrush in their mouth, which is that white coating, very, very painful. They can't eat with that. So a lot of things to think about. And again, what's their appetite like? Do they have any food intolerances, any food allergies? What are their normal bowel habits like? And then social data. So we want to look at their age, their sex. Remember, we told you that nutritional deficits are possible as you get older. What's their family history like? What's their lifestyle like? What's their educational background? We do know that there is a direct correlation with education and having a healthier diet. Information about their occupation. So if they're really, really busy and they work 60 hours a week, they might not have time to exercise. What's their sleep pattern at night? How much sleep are they getting? What time do they go to bed? What time do they wake up? Religious and cultural background is important. And then we want to know their use of alcohol and tobacco. And then we want to know their source of income and how much they budget each month for food. All right, so we said we were going to talk about that anthropometric data. So these are measurements that we take from our patient. They're measurements of the size and proportion of their bodies. We use these measurements to determine their body dimensions. So we look at their height, we look at their weight, we look at their, we do skin fold measurements on different parts of the body. One of the areas we do it on is their triceps. And we measure their skeletal muscle mass and their fat stores. So it gives us a lot of information about the composition and the proportion of the body. We also look at their BMI and their waist circumference. So when we're trying to figure out BMI is just a ratio of weight in kilograms to our height in meters, okay? It's a correlation between the two. It's basically our kilograms over our meters squared. Our BMI is said to be a reliable indicator of the total fat stores within the body. When we do waist circumference, we measure our waist by placing the measuring tape snugly around the patient's waist at the level of the umbilicus, which is the belly button. If you look in your book, figure 36.1 in your book will show you exactly where you should put the measuring tape, and it gives you a good idea how you would measure that in a patient. And it is said to be a good indicator of abdominal fat. We do know that there's an increased risk of cardiovascular issues with patients that have waist sizes of 40 inches or more in men or 35 inches or more in women. So if they fall into that category, their risk of having a cardiovascular issue is increased a great deal. Biochemical data. So we said we're going to look at certain labs. So we're going to look at hemoglobin and hematocrit. So these are measures of plasma protein in our body that also reflect a person's iron status. So if they don't have good nutritional intake, they might be deficient in iron. So this would be an indication of that. We look at albumin because it's a good indicator of patient's nutritional status. It looks actually a few weeks back. It tells you what their nutritional status was like just a few weeks ago when that blood was drawn. We look at our BUN. So in our patients that have an increased BUN, that could be indicative of starvation, high protein intake, or severe dehydration. If we see a patient that has decreased BUN, it could also be a symbol of malnutrition or overhydration. We will also look at their creatinine level. So if our creatinine level in our patient is increased, it is a sign that they could be dehydrated. There's something going on with the kidneys. And then if it's decreased, it could be due to a reduction in total muscle mass or some severe malnutrition. So you guys need to know what our BMI is. You need to know what it is and how we measure it and why we use it. And then you guys also need to know about your metabolic rate, which we talked about. And you are going to have to do a BMI calculation for your test. So our body mass index, so our BMI, like I said, is a ratio of our weight in kilograms to our height in meters. And it is said to be a reliable indicator of our total body fat. So if you want to calculate a person's BMI, the first thing to do is you take the patient's height in meters, and then you square that number. So you need to multiply your height in meters by itself first. So for example, if you are 1.75 meters tall, then you would multiply 1.75 by 1.75, and you would get 3.06. The next step is to divide your weight in kilograms by the meter squared. So you need to divide your weight by your height in that squared, so that 3.06 number that we got. So if your weight is 75 kilograms and your height in meters squared is 3.06, then you divide the 75 by the 3.06 for an answer of 24.5. That 24.5 is your BMI. So the full equation is kilograms divided by meter squared, in which your kilograms is equal to your weight in kilograms, and M is your height in meters. So if you have a BMI of 24.5, you would compare it to the BMI chart. So a 24.5 would be a healthy weight. Below 18.5 is considered underweight. A BMI of 30 or greater is obese. And then a BMI of 40 or greater is considered extreme obese. So you guys need to know how to do this because we will be having this on your exam. So your basal metabolic rate. So males typically have a higher basal metabolic rate because they have that larger muscle mass. Our basal metabolic rate is about 1 calorie per kilogram of body weight per hour for men. And for women, it's about 0.9 calories per kilogram of body weight per hour for women. Factors that we would see that would increase our basal metabolic rate. So growth spurts, those, from infant all the way up through, late adolescence, early adults. Some say that people are still growing up until like 21 or 22 years old. So growth, infections, fever, when we're stressed out, any kind of emotional tension, when we see extreme environmental temperatures, so extreme areas of heat or cold temperatures, and then when we see an elevation of certain hormones in our body. An example of that would be epinephrine or our thyroid hormones. And then factors that decrease our basic metabolic rate would be aging, prolonged fasting. So it could actually have the opposite effect. A lot of people fast thinking that they're going to lose weight when actually they will gain weight because it decreases their BMR. And then sleep. All right, so clinical data. So we want to talk to patients about any barriers that they have to eating. So do they just not have time to eat? Do they work a crazy schedule? Are they working and in school? Maybe they don't have transportation. They can't get to the store like they normally could. So they don't have access to good quality food. Do they have any kind of medical condition that keeps them from being able to eat? So did they have a stroke? Did they have any kind of dysphagia? Did they start a medication and they feel nauseated? Did they just have bariatric surgery and maybe their intake isn't to where it should be? Have they been suffering with depression? Have they been really stressed out about something? They just don't have an appetite. Find out look for any kind of medical condition that could be a barrier to them eating. We said dysphagia, that's that difficulty swallowing or the inability to swallow. We see this a lot in our stroke patients. And we know that patients that have dysphagia are also at an associated risk, an increased risk for aspiration because they're not swallowing properly. What kind of dental problems do they have? If they come into the hospital and they didn't bring their dentures, their nutrition is going to be impaired because they're really not going to be able to eat certain foods. And if they can't afford to have dentures and they've lost teeth, as thinking of the older adult, they might avoid certain foods because they're just difficult to chew. But it could be nutrient-rich food that they need in their diet. And then any sensory deficits. So are they blind? Can they not see to prepare their food? Are they taking a medication which has affected their taste or their smell? Have they had an infection or some type of an illness that can affect their taste or smell? So I'm thinking of COVID, which is, I've heard patients that have had COVID 6 and 9 months ago that still don't have their taste or smell back. Patients on chemotherapy lose their sense of taste. Certain medications cause you to lose your hearing. And then any kind of physical deficits that would prohibit them from being able to feed themselves. So if you have a patient that just had a stroke and they predominantly use their right hand and it was on their right side, they're probably not going to be able to feed themselves. So we're going to make sure that we're going in and we're sitting with them during lunchtime and we're feeding them. Do they have a broken arm and they can't feed themselves? We want to look for issues like that. So we're not always just looking for issues. We're also assessing them for risk for issues. So they might not have this issue yet, but it could become an issue if we didn't recognize this certain thing and make implementations to fix it. So some nursing diagnoses that we might see, so for imbalanced nutrition, if that's your problem, we might see imbalanced nutrition more than the body requirements. So this would be obesity or risk for overweight. Imbalanced nutrition as the etiology, it could be fatigue, it could be constant. So maybe they're just sick and they don't have the energy to eat. Maybe they're constipated and they can't get anything out, so they don't want to take anything in because they feel full. Risk for impaired skin integrity. Wellness diagnosis, so readiness for enhanced nutrition. So maybe the problem has resolved and now they're at a spot where we're really going to start working on repairing that nutritional deficit. Less or more than body requirements, so we can have a self-care deficit with feeding, a deficient knowledge where they just don't know how to calculate nutritious foods or what foods are nutritious, impaired swallowing, risk for aspiration, readiness for enhanced nutrition, expresses willingness to enhance their nutrition and have a healthier diet, risk-prone health behavior related to a negative attitude towards healthcare. So these would just be your patients who are not very compliant, that don't want to make any changes. And then risk for ineffective peripheral tissue perfusion because of that sedentary lifestyle. All right, so when we are planning, so our ultimate goal is to maintain or to restore nutritional status using foods that the patient likes and that they can tolerate as appropriate for the situation that they're in at the present time. Sometimes our patients are NPO and they really would love to have a steak and a baked potato, but the situation right now doesn't permit that. So we have to support their nutrition as best as we can for that current situation. So the patient will be able to attain and maintain an ideal body weight as indicated by our BMI calculator and our waist circumference measurements. We want our patients to eat an adequate diet, but not excessive in nutrients. And we want that diet to be based on the 2015-2020 Dietary Guidelines for the Americans, which is that My Food Plate that we talked about a couple slides back. We want our patients to eat a variety of food in each of 3 or more meals. And we want them to follow the appropriate modified diet if we have to give them a modified diet when necessary, so that those recommendations will help restore their health. It will help avoid further disease, any kind of reoccurrences of the issue that they're having right now, and it can prevent or delay potential complications, which is ultimately what we want. So our interventions, well, we need to be a teacher. We need to teach them nutritional information. So maybe we need to sit down with them and actually have them plan out a menu of what they're going to eat for 3 meals. And then you look at their menu that they've planned and try and give them some constructive criticism. So if they ask for, if he's going to have some broccoli with a cheesesteak and some French fries. So then you could sit down with the patient and say, the broccoli is a great choice. Explain to them how much fat the cheesesteak has. You can offer other ways that they can incorporate that in, maybe just having a small steak instead of the cheesesteak, or not adding the mayonnaise, kind of curtail it a little bit to make it a little bit more nutritious. Show them how you do it. Show them how to calculate those meals in the course of a day so that they can see what their daily intake of caloric intake would be, so that they can compare it to what their recommendation is. So if we recommend that they have 1,800 calories a day, but after they've planned these 3 meals and a couple snacks, we put it in and it's at 3,200, well, that kind of puts things into perspective for them, and they can see how the choices they made have caused them to gain weight, or how it can cause them to gain weight. We also want to talk to them about their drinks. So a lot of their drinks that they have, if they're drinking sweetened teas and a lot of sodas, that is like empty calories. So we can talk to them about drinking water or unsweetened iced tea, sugar-free drinks, things like that. Talk to them about packing their lunch when they go to work, if they go to work, instead of buying out. You know what the nutritional content is of food that you make, and you know that it's healthier. We want to monitor their nutritional status, so they should be weighing themselves, coming back into the primary care facility to follow up with their doctor. And then we want to make sure that in the hospital setting, or if it's in a long-term center, that we're assisting them with eating. So if we know they need dentures, we want to make sure that they have their dentures cleaned and in their mouth at all their meals. If they need hearing aids to eat, or not to eat, but if they need hearing aids, they need to be able to hear you. They need to know when it's time to eat. They need to know what you're explaining to them about their food. So they should have their hearing aids in. They should have their glasses on. All this should be in place before their mealtime. We want to help them when their meal tray comes by opening containers, especially if they have any kind of physical deficits in their hands or any weaknesses. Open those milk containers, take the tray apart, cut their meat for them. You can apply their condiments to their food, put butter on their rolls, things like that. Put their spoons and their forks where they need to be. Try and involve the client as much as possible. So you want to solicit the client's preferences regarding the order of items eaten and the pace in which they eat. So this is a big thing for me. So when I'm in the hospital, if patients are not alert and oriented to 4, and they're really not capable of picking up the phone themselves and calling to order their lunch, a lot of people put our patients on what they call a house tray, which means that all 3 meals, the kitchen's just going to send them a pre-made meal. So they might not like what comes, and they might not eat it. And that's an ongoing issue with a lot of our hospitalized patients. Some nurses and some techs don't really want to take the time to make that phone call 3 times a day to order their food. Most patients, even if they're confused, know what they like to eat. Take that extra time, go in the morning, don't put them on that house tray unless they're completely out of it and they're not even conscious, and then they're not even eating. What do you like to eat? Do you like eggs? Oh no, I don't like that. I like this. Take that time, because if you're ordering things that they like, they're more than likely they're going to eat it. Or if they say that they don't want it, once it comes, they wind up seeing it and it stimulates them to eat. So make sure you're ordering foods that they like. You can encourage family members to bring in food that they like and put it in the refrigerator and heat up for them later. Sit at the client's eye level and make eye contact with the patient when you're sitting with them and you're feeding them. It makes them feel like you're engaged with them. It's a person-centered atmosphere. It makes them feel comfortable. You can place a napkin over their clothes so that you can protect their gown so that they don't spill everything. Sometimes patients, even if they have physical deficits, they still want to do things for themselves. So if they still want to feed themselves, yeah, put a little napkin or a towel over top of them so in case they spill something, it doesn't get all over their gown. And then any kind of special eating utensils if needed when possible. All right, so stimulating a patient's appetite. So we can do this by serving small, frequent meals. When we serve smaller, more frequent meals, mealtime tends to be less overwhelming for the person, and they don't feel like they're having to eat such large amounts of food. As we get older, you'll see with a lot of these older patients, they just can't consume an entire plate of food. They'll have 4 or 5 bites, and then they're done. So instead of just having them get 4 to 5 bites 3 times a day, getting those smaller meals is better for them. They're going to get more in their diet, and they're going to eat more frequently, but they're going to feel more satisfied and they're going to get the nutrients that they need. Solicit those food preferences and encourage those favorite foods from home or prepared when at home. Encourage good oral hygiene. So you want to make sure that you're brushing their teeth every day so they don't have a nasty taste in their mouth. It's going to make their food taste better. Clean their dentures, make sure that they're well fitting and in place. Remove clutter from the eating area so that they can concentrate on their eating. Arrange their food tray so that the patient can eat their food easily. So thinking about the patient who might be legally blind or really have a problem with their vision, especially if they come in and they don't have their glasses, put the spoon in their hand and then tell them where their food is on the plate. So you can kind of describe it as a clock. Well, at 6 o'clock, this is your mashed potatoes. At 9 o'clock is your green beans. At 2 o'clock is your chicken. And that way they can visualize that clock in their mind and they can reach forward in front of them and find and navigate their food tray. Be sure that any prepared food looks attractive. I mean, in the hospital setting, we don't really have a lot of control over that, but certainly if their food tray comes up from the kitchen and it looks terrible or it's burnt, if it's not something that you would eat, send it back and order something else for your patient. Schedule procedures and medications at times when they're least likely to interfere with appetite. May not always be able to do, but some things to keep in mind is some patients will go off for procedures later in the day. And you know they're probably going to become, like at my facility, you can't order past 6:30. So if I have a patient that goes off around 1 and I know they're going to be coming back around 5, I call the doctor around 5:30 and I say, hey, look, the patient's going to be coming back soon. Can you advance his diet so that I can order him a tray so that way it's here? And I'll order them something that can be reheated. That's not going to be disgusting, like a grilled cheese sandwich you wouldn't want to order because that doesn't reheat well, but maybe something like spaghetti, or I'll order like a cold sandwich and have it in the refrigerator for when they get back, because once they get back, if the kitchen closes, they don't get any type of a meal at all. And then we want to make sure we're controlling their pain, their nausea. If we can control their nausea, they might actually want to try eating something. If they're not in pain, again, they might have somewhat of an appetite. So when we're providing oral nutrition, there are different types of diets that our patients can have. So they can have a clear liquid diet. They can have, which is like your broths, anything that's see-through, a clear liquid. You can have your full liquid diet, which is cream of wheat, cream of chicken soup, tomato soup. You have soft diets, GI soft, high fiber diets, shop diets, pureed diets. There's a lot of different diets. Patients who cannot have a diet, either for a variety of reasons. Maybe they're going for a test, or maybe they have had a stroke and they can't swallow right now, or maybe they're just too lethargic. So we made them NPO until they're more awake. Just because they're not eating doesn't mean that we should not be doing good oral hygiene, even more of a reason to do good oral hygiene frequently, because they're not getting anything in their mouth, and their mouth can get like this white or yellow slime in it. It can become very, very dry. Their lips can be cracked. So we want to make sure that we're doing good oral hygiene for our patients who are NPO at least every 4 hours. If it's an adult, like a lot of our patients that come in with pancreatitis, the only way to fix pancreatitis is to make them NPO and give them high amounts of fluid. But sometimes this lasts for days at a time, 4 to 5 days sometimes, they're NPO. So I always like to give them like a little cup with ice water in it, and we have these little green sponges on sticks. They can just dip them in there and then moisten their mouth. We don't want them to swallow the water, but at least it moistens their mouth. Provide the patient with ice chips or sips of water as allowed. Urge the patient to avoid watching others eat. I mean, and really, if they're having visitors, they should not be bringing food in. That's just mean if they're NPO. So if visitors are going to come and visit, just tell them, maybe you shouldn't eat in the room because they're not allowed to have anything and they're really hungry. And then suggest alternate activities at mealtime. So that kind of like takes their mind off of the fact that they can't eat anything. So sometimes if patients cannot take food in on their own, or they're not getting the adequate nutrition, then we have to do other things. So we can do enteral nutrition. So this is when we pass a tube into the GI tract and we administer a formula to them that contains the adequate amount of nutrients. When we provide nutrition via an IV therapy, we can do parental nutrition, which is short-term, and it can be applied to a very short vein in the patient's body, or we can do total parental nutrition, TPN is how we say it in the health field. So TPN is more long-term. So parental nutrition is short-term, TPN is long-term. Your TPN is very highly concentrated with a variety of different nutrients, and it's a very hypertonic nutrient solution. Because of its composition, it can only be applied in larger veins near the chest or the neck of the patients. So these patients usually will have some type of a central line. It could be an IJ, like an internal jugular, an external jugular. They might have a central chest line. If they have a port because they have cancer, we could use their port. So it needs to be it ideally should be a larger vein. It can be, however, given peripherally if the concentration is appropriate, depending on what type of medication it is. I've never really seen, I think with the exception of one time, I saw TPN giving in just a peripheral IV. Most of the time it's not. So enteral nutrition involves the passing of a tube into the GI tract to administer that formula. It is a way of providing nutrients for patients who are unable to consume the proper amount of nutrients through their oral intake. But they have to have at least a partially functioning GI tract that's accessible and safe to use. So that is kind of a prerequisite in determining whether or not they can have enteral nutrition. Sometimes you'll see enteral nutrition will augment an oral diet. So, or it could just be the sole source of nutrition. So it might be the only type of nutrition that they have, or maybe they will eat smaller meals throughout the day, but then at night they have this enteral nutrition. So you can see it either way. You can use a nasogastric tube inserted through the nose and then it goes into the stomach. Or you can use a nasointestinal tube, which is passed through the nose and into the upper portion of the small intestine. TPA is very highly concentrated, hypertonic, like I said earlier. It's administered mainly 90% of the time through that central venous access, or in some instances, depending on the concentration of the solution, it can be peripheral. Peripheral parental nutrition, PPN, is obviously less concentrated, and it's administered through that peripheral vein. All right, so patients that require short-term nutritional support. Usually what we mean by short-term is less than 4 weeks. Anything over that, we kind of think of it as more of a long-term. For short-term nutritional support, we usually use the nasogastric tube, which is the one that goes through the nose and into the stomach, or that nasointestinal tube, which is passed through the nose into the upper portion of the small intestine. These are less invasive and they're appropriate for a shorter term. When we put that NG tube in, we want to make sure before we use it that we have that x-ray done, right? That good x-ray that shows exactly where it is. You're going to do measurement of that aspirate pH and visual assessment to see what your residual looks like. Measurement of the tube length and marking. So just to backtrack on the pH, you're never going to see that in the hospital setting. I have it included in your slide because we do it for your testing, and we expect you to know it for your testing, but you won't really see that in any facilities. And then the measurement of the tube length. So when we measure an NG tube for a patient, you take the end of the tube and you hold it to their nose, you bring it around to their ear, the bottom of their earlobe, and then you bring it down to their xiphoid process. When you get to their xiphoid process, you look at where that ends in relation to the xiphoid process. Your tube has a numbering system on it. So whatever number you're at, that's how far you're going to want to go down the nose. So usually what I do is once I get that measurement, I look at my tubing. If it says 52, I get a piece of tape, I wrap it around my tube right at that number, 52. So that way, and the tape kind of hangs off it's like a flag. I fold it in half. So that way, when I'm putting the tube through the nose, I know to stop when that piece of tape gets to the end of the nose. It won't go any further. Plus, it's a good indicator if for some reason the patient's been antsy or something's happened and it starts to come out of the nose, you know that number, you know where that placement number was. So you want to make sure you have the proper measurement and tube marking. And then you also would need to get an x-ray to confirm that nasointestinal tube placement. So long-term nutritional support, usually more than the 4 weeks. If we have to have long-term nutritional support, then we're probably going to do a more permanent option, which is a tube that can be placed through an opening that we create surgically into the stomach. We call that a gastrostomy, or if we go into the jejunum, it's a jejunostomy. The gastrostomy is the preferred route to deliver enteral nutrition in a patient who is comatose, just so you know. That's usually where they decide to go. The gastroesophageal sphincter will remain intact, which makes regurgitation and aspiration less likely than with G-tube feedings. Placement of a tube goes into the stomach. It can be done by a surgeon or a gastroenterologist. They do a percutaneous endoscopic gastronomy, which is also called a PEG. So sometimes you hear it as a PEG tube, or a laparoscopically placed gastrostomy tube, either one of those. So this would be an example of your PEG inserted into the jejunum. So you can see further up here in the stomach, that's where your gastrostomy would go, right here. And then this is what it looks like. So on the outside of the skin right here, you have that little circle that's attached to your tube that prevents your tube from going further inside. And on the other side, you kind of have like this little balloon that's blown up, preventing it from being pulled out. With that being said, if the patient is confused and pulls hard enough, it can come out. I've seen that happen before. So always be aware of that. And then you can see the end of the catheter ends. This is where the food is delivered. So it goes through the jejunum and it goes all the way down here into the large intestine, which is why there's no residual checks with that, because there's no residual, only residual in the stomach. All right, so parenteral nutrition. So this is when inadequate oral intake is expected over 7 to 14 days. So this is something as a nurse that you guys need to think about. If your patient goes 1, 2, I don't know, 3 days without something to eat, as long as they're getting like fluid, okay, that's not really a problem. But when you start thinking in longer periods of time, you need to start thinking, oh, you need to have a plan. You need to start talking about what are we going to do for this patient, usually by day 4. What are we thinking about? If things don't change in the next day or 2, what's our plan? Let's start talking to family members. Let's decide what they want. These issues, I've seen this become ethical issues in the hospital before, where these patients go for long periods of time without food, and it's not appropriate. So as a nurse, you're always advocating for your patient. You're always looking for these opportunities to advocate for them and making sure that they have proper nutrition. So that parenteral nutrition is the delivery of nutrients by the vein. Parenterally means outside of the intestinal tract. That's why it's called parenteral nutrition. It's an infusion of nutritionally complete hypertonic formula. It can be life-saving for patients who don't have a functioning GI tract. Also used for other clinical conditions such as critical illnesses, patients that have acute pancreatitis. So sometimes pancreatitis can go on for so long that they have to have some type of parenteral nutrition. I've seen it last upwards of 2 months sometimes in some patients. They can't have anything by mouth, so they have to have this parenteral nutrition. Patients who are getting liver transplants, patients with AIDS, patients with cancer, receiving bone marrow transplants. Overfeeding a patient can cause a life-threatening condition known as refeeding syndrome. You guys need to know what this is. Refeeding syndrome develops when someone who is malnourished starts to eat again. The body starts working, it starts digesting and metabolizing the food again, but then because they're not used to doing this, it causes this huge shift in the balance of all those electrolytes and fluids. And we know what happens when we see sudden shifts in our fluids and electrolytes. Our homeostasis is off. So this can be a life-threatening issue. Symptoms of the syndrome usually become apparent within several days of treatment. So it's not going to be the first day, but it's going to be several days after, maybe day 2, 3, 4. And this absolutely can be fatal. Another thing for you guys to remember is that this is a medication. So you're checking your patient, you're identifying them, their wristband, their name, their date of birth, all those identifiers, you're doing your med checks. Make sure you're explaining to your patient what they're getting, why they are getting it, how long they're going to be on it, where we're giving it at. They need to have all this good information. All right, so catheter placement. So what type are they going to get and where are they going to get it? So this really is dependent upon how long they're going to be on the therapy. So it's the patient's anticipated length of need is going to influence what type of access they get. 2 to 4 weeks, they might get peripheral access. Anything over that, they're going to need that central line. So PN can be infused via the peripheral or central veins. It's perfect for short-term use in the hospital, and a temporary central venous catheter is placed percutaneously into the subclavian vein. If PN is expected to be more than a few weeks, then the catheters that are a better choice are going to be your central line. It's a central line. Some people call it a Hickman catheter. Different facilities call it different things. So a Hickman catheter or a portacath. So a portacath would be when usually your patients that have cancer get portacaths. It's when they go in and they make an incision under the skin. They have this little round thing that they insert, which goes into that major vein. And then you access that each time that they need something. It's good for 7 days once you access it. Or you can have a Hickman catheter, which is just like a central line. When you have a central line, you can have a central line that has 1 port on the end of it. You can have it that it has 2 ports, or you can have it that it has 3. If you have a central line that, now this isn't anything you need to know for a test, this is just for clinical knowledge. If you have a patient that has a central cath and he's getting parenteral nutrition through that, you cannot use it for anything else. It always has to be just dedicated to the parenteral nutrition. If you have a central cath that has 3 lumens on it, so it has 3 little piggy tails and 3 little pieces, 3 little end ports, then one of them just have to be dedicated. Then you could use the other two for fluids or medications, whatever else. What I like to do is if I start parental nutrition on a patient and they have like a triple lumen or a double lumen, that's how we call them in the hospital. I take a piece of tape and I mark that tubing of that central line that says that it's for the nutrition, just so anybody that comes behind me knows. Or you can also use a PICC, which is a peripheral inserted central catheter. So different than just your peripheral IV, it's a central line, but it's peripherally inserted. Nurses can insert these, usually higher up in the arm. So this is a good diagram of where you could see a PICC line or a midline catheter. These are the different veins we could use, and you can see how it all goes back. It leads back to the heart, into that subclavian vein. All right, a placement of a triple lumen, non-tunneled percutaneous central venous catheter. That's what you're seeing right here in A. So this is a triple lumen. It has 3 little piggy tails coming off of it. You can hook things up to each one of these: medications, IVs, parental nutrition. One of these has to be dedicated for your nutrition. And over here, this is that port we were talking about. This is a placement of an implanted port within the tip of the subclavian vein. It's an angled needle is then inserted through the skin and into that rubber septum that goes into the port. And you can see right there that little piece of equipment that we were talking about and how it goes into the subclavian vein. So that's a port. All right, central PN, so central parental nutrition is administered via that central venous catheter. The central lines access those large veins, and their distal tips usually end in the distal vena cava or the right atrium, those larger areas. Central venous catheters may be single or multi-lumen and are most commonly placed in the jugular, the subclavian, or the femoral veins. They may be non-tunneled, which is a percutaneous non-tunneled central cath, or peripherally inserted central catheter, which is a PICC. They can be tunneled, or you can use implanted portacaths. So what is the composition of our parental nutrition? So they give our patients proteins, carbohydrates, fats, there's electrolytes in there, a variety of vitamins, and trace elements, all combined with sterile water. This concoction is usually made or compounded in the hospital pharmacy. They make it up and they send it out to you. They also make something that's called 2-in-1 formulas. So they have dextrose and amino acids in them. These are what most hospitals use. And then lipids are given separately through another infusion, and that's where they get their source of energy. And then there's a 3-in-1 formula, which is your dextrose, your amino acids, and your lipids. So standard formulas of parental nutrition, so tube feeding formulas that contain whole molecules of protein, also known as intact or polymeric formulas. The most commonly used formulas are appropriate for most patients that require parental nutrition. They contain whole proteins that are extracted from milk or soybeans, such as casein, caseinates, soy protein, whey protein, milk protein, or you can see them in a variety of a combination of those. And then you have variations of those standard formulas that include formulas that can be very high in protein, some can be high in fat, some can be high in calories, some have fiber in them. Really just depends on what your patient needs. And then the thing to think about is that they have to have normal digestion and absorption for these standard formulas. If they have issues with digestion and absorption, it's not going to help them. We have hydrolyzed formulas. So these are elemental formulas, which are made for patients who have issues with digestion or absorption. So these people would be patients that suffer from inflammatory bowel disease, something called short gut syndrome. We see this in our cystic fibrosis patients and patients that have a variety of different kind of pancreatic disorders. We also have specific formulas that are created for patients that have liver disease, patients that have HIV or AIDS, and they require that immuno support. We have completely hydrolyzed formulas, which contain only free amino acids as their source of proteins. We have partially hydrolyzed formulas, which contain proteins that are already broken down for the patient, makes it easier for them to absorb it. And then we have formulas that are intended for patients with impaired digestion or absorption issues. So, when we administer parental nutrition, we are always going to administer according to our facility process or protocol, policy, whatever it is. We always start this process very slowly. Usually the goal is for them, and this is kind of a large goal, to receive 1 liter in 24 hours. I'm not sure that I always see that. I guess in some people that's appropriate. But it starts very slowly. So usually when the orders come over, you will see that they're supposed to get 10 mLs. And you know how many 10 mLs is. It's a very small amount. 10 mLs every hour. It's always going to be on a pump. That's the only way you can measure it. Not an IV pump, but it'll be on like a tube feeding pump. We call them a kangaroo. You've seen them in the clinical setting. We're in the lab. So usually they start off at 10 mLs. You do that 10 mLs every hour for 4 hours. Then after the first 4 hours, you check those residuals. If the residuals are good, you increase by another 10. So the order usually says start at 10, increase by 10 every 4 hours until you get to the maximum goal rate of, and then they'll list the goal rate. It's different for everyone. Some people it's 45 an hour. Some people it's 75 an hour. I think one time I saw someone who was 100 an hour, which was probably the most I've ever seen. So the goal rate is always set by the doctor. And how you titrate it is always also set by the doctor, but that's usually how it happens. The formula that comes up is only good for 24 hours. So when you start it, just like any other medication that you would hang, you're going to put your initials, the date, and the time that you started it. You're going to discard any unused parental nutrition solution within 24 hours of starting. Any continuous drip by pump infusion is needed in order to maintain a slow, consistent flow rate. So you wouldn't just want it to go by gravity. Rapid changes in the infusion rate can cause severe hyperglycemia, obviously, or hypoglycemia. So some patients, these have a lot of glucose in them, some of them. So it could cause either one of those problems. And then we know that there's always the potential for coma, convulsions, or death. All right, so what are some complications that we can see with parental nutrition? Well, we could see sometimes if we give them, sometimes the solution that we give them is not good for them. So it can cause GI issues, they can get diarrhea, it can cause high glucose, high blood sugar, so then we have to curtail that a little bit. Sometimes they might even have to go on insulin until we get the exact combination correct and to keep their blood sugar controlled. Sometimes we can give them too many fats or lipids and they can get high cholesterol, hyperlipidemia. If something's wrong with the central line or we're giving the wrong solution through the wrong line, we could see phlebitis. Always the potential for those fluid and electrolyte imbalances. We could cause metabolic alterations. You know, when we put these, when we're administering through PICC lines, central lines, and ports, these are central lines. So we always have to be cautious that we handle these aseptically. So when you handle them, you always have to handle them with gloves. You have to make sure that you're scrubbing the hub on the end of all those reflux valves that are connected to your lines. If you're not, anything that's on that end of that reflux valve is going to go right into the patient when you hook them up to their nutrition, or if you're flushing the line. So you should have your swab caps on the end there when it's not in use, and you should be scrubbing that hub in between. And certainly if there is no cap there. Make sure you're changing your reflux valves in between every 24 hours, or when you do blood draws. Make sure you're changing the dressings on them ports when they're supposed to be, so you don't want to prevent any kind of catheter, any kind of central line infection. There can always be some type of an insertion problem. You put it in and then it kinks inside the patient and it doesn't work anymore, and they have to go in and take it back out and put another one in. Sometimes we can see liver and gallbladder disease as a side effect of these of this nutrition. Not all the time, but it can happen. So next we want to evaluate, is our nutritional implementations, are they working? So we want to make sure that we're always working in conjunction with our patients. We want to meet their expectations. We want to talk about any concerns they have. Ideally, for patients that are alert and oriented, this is not the ideal situation for them. They need a lot of education and they need to be able to talk through things. You want them to be able to discuss any of their concerns. You want to advocate for them, make sure that the doctors are on board with their concerns and that we are helping to meet their needs. Our care plan should always be updated and reflect our achievable goals and outcomes. So we always want to have goals that we think are achievable, not too unrealistic. Nutritional therapy often requires ongoing comparisons to view a patient's progress. So what are we going to do? Well, we're going to do that BMI measurement, right? We're going to look at those labs, the hematocrit, the hemoglobin, the albumin, daily weights, things like that, that can be an indicator of good nutritional status. Strict I's and O's, bowel movements, things like that, consistency of bowel movements, blood sugars. When expected outcomes are not met, we're going to revise that nursing interventions based on the patient's needs. And then always make sure that if needed, we are having consults with the multidisciplinary team. All right, so we're a little bit more than halfway through. So let's stop here. We'll come back at 8 o'clock. We'll take a 15-minute break and then we'll start off with obesity. Okay.
Sounds good, thank you.
Yep, you're welcome. Guys. All right, so let's pick up where we left off with obesity. All right, so obesity, is it an epidemic? The prevalence of obesity considered as having a BMI of greater than or equal to 30 in young Americans is over 36%. Obesity is one of the most common causes of preventable death. And historically, the study of obesity and eating disorders have been separate until recently. But now, as a lot of research has taken place and they've had more studies, they are seeing a lot of common ground between the two. So they're starting to look at obesity in a different light. The causes of obesity. So obesity can occur when we eat more calories than we expend over time. So taking more calories in than we burn. Excessive caloric intake, ready access to an abundance of food. Doing this 1 or 2 times isn't going to cause an issue, but when we have access to an abundance amount of food on a regular basis and we partake in that, then obviously that can lead to obesity. We know if we have a sedentary lifestyle, that can cause obesity. Some people are able to burn hundreds of extra calories in the activities of daily living, which will help to control their weight. Lucky are those people. It's not a lot of people. There is a combination of a genetic and an environmental factor in our composition, the way we're made. If we're going to how our body burns fat, if we'll have an issue with obesity. It can also be very difficult to distinguish between factors that are hereditary. So does this run in our family? Or if they're learned diet and lifestyle habits from how we were actually raised. Patients that have a low resting metabolic rate, especially as we get older, we know that that's a big issue. And then pregnancy, obviously, and a lack of sleep can also cause us to be overweight and obese. We know medications can actually cause obesity, so antidepressants, certain diabetic medications, steroids can cause us to retain weight, certain beta blockers. There's a couple anti-seizure medicines that cause that, and some of our antipsychotics. There is a lipoprotein lipase called LPL. A deficiency can lead to hypertriglyceridemia, which is elevated triglycerides in our blood, which can then lead to insulin resistance, which then leads to obesity. There is a theory that your book talks about. It's called resetting. It's called the set point theory. So we talk about resetting our set point. So this goes off the philosophy that our body has a regulatory system that helps keep us at a steady state, or what they call a set point. Theory suggests that your weight may go up or down temporarily, but will also ultimately return to that normal set range. That philosophy also believes that there are certain, they also believe that as you get older, it might get, that set point may get to a certain point and it doesn't go back to that normal range. So then people talk about different things that they can do to reset that set point. So some people try fasting, some people try eating different amounts of calories per day throughout the week. Like maybe one day you'll have 1,500 calories, and then the next you'll have 2,000, and the next you'll have 14. So kind of trying to trick your body a little bit. And then leptin. So leptin is actually a hormone that we see that causes anorexia or starvation. Its capability is to reduce our food intake and our body weight. So patients who are obese are found to have high levels of circulating leptin. Ghrelin is a protein that is produced by stomach cells that enhances appetite and decreases energy. So you guys can think of it, the hormone, a protein, ghrelin will always say, I'm hungry, I'm hungry, I'm hungry. And then the leptin says, I've had enough, I've had enough, I've had enough. Kind of cuts things off. So they work in opposite ways of each other. So having readily accessible low-cost food, snacking a lot or having snacks that are not healthy, having a high intake of added sugars, eating food away from home, eating out all the time, breakfast, lunch, dinner, eating portion size of restaurant meals. We all know that restaurant meals do not give us appropriate portions. Having a decrease in our energy expenditure related to labor-saving devices. So, driving cars instead of walking or riding, things like that. And an increase in sedentary leisure activities. So we know that today's society plays a lot of video games. They don't go out of the house as much as some other generations. So these are considered sedentary leisure activities. So the most common complications of obesity are going to be your insulin resistant type 2 diabetes, not type 1, but type 2. You're going to see patients that have hyperlipidemia, hypertension. They're going to have cardiovascular disease. They're going to be at risk for having strokes. These diets can cause the formation of gallstones and cholecystitis, sleep apnea, respiratory dysfunction, and increased incidence of certain cancers. So there is a direct correlation between an increased waist and breast cancer and other cancers. I forget exactly what it was. I just read it not too long ago in a certain study, but people that have an increased abdominal girth are said to be, I don't know, I think it was like 37% more likely to get cancer than other people. So there's a direct correlation with being overweight and developing cancer for sure. Increases the risk of complications during and after surgery. Obesity is considered to be a major contributor to preventable death. So it's something that we can prevent. Obesity presents psychological and social disadvantages. Oops. And then negative social consequences as well. So this is just a list of all the things that unhealthy diet and obesity can cause in our body. We're not going to go over all these. You can look at this in your spare time, but there is something that affects almost every system in our body. So this is a good example of why we need to be healthier, especially because we're nurses and we're teaching other people. And we know the complications. I can honestly say that when I graduated nursing school, I was 40 pounds heavier. Yeah, I had gained 40 pounds in nursing school. I mean, my diet really consisted of combos and gummy bears. That's all I ate when I was studying almost every night. And once I became a nurse, I was always disgusted with myself because I had gained weight, but I guess I just wasn't ready to do anything about it. And then I started seeing these patients that would come in that had diabetes and they were getting their fingers cut off and their toes cut off. And then I started really seeing the side effects and the long-term issues related to obesity and not taking care of yourself. And that really made me completely turn around my diet and the way that I look at food and taking care of yourself. I still don't exercise like I should. That's on my goal, but at least I have my nutrition where it should be. So we're all a work in progress. All right, so risk factors for obesity, race. Obesity rates in American adults are highest in the African American population, followed by Hispanics and Latinos, and then Caucasians. When we look at sex, Asian American men and women have the lowest rates of obesity, and it is more common in Black or Hispanic women. Our diet, so eating and drinking a lot of foods and beverages that are high in calories, sugar, and fat, we know will cause us to become overweight, and drinking a lot of beverages that are high in added sugars. Genetics also has a part to play, so the chances of being overweight are greater if one or both of your parents are overweight or have obesity. Your genes can also affect the amount of fat you store in your body and where you store it on your body. Psychological inactivity. So if we spend inactivity, if you spend a lot of time sitting or lying down, maybe you have a job where you sit all day and then you come home and you sit, having limited physical activity, maybe even because of an illness, if you broke a leg or you broke a hip or something like that. So remember, identifying our patients at risk for developing certain things is also part of our job. Psychosocial problems, so we see it with depression and we have to think about our eating disorders. Environmental issues, so where do we live? Where do we play? Where do we work? Where do we worship? That can affect our eating habits and our physical activity, and our access to healthy foods and the places to be active. Vending machines, cafeterias, or special events at your workplace or place of worship may not offer healthy, low-calorie options. I feel like at work, there's always unhealthy foods. Whenever they give us anything, here, you're short-staffed today, here's a pizza, or here, you did great last month, here's a pizza. It's really never healthy food. They bribe you with unhealthy food all the time. And then we want to think about economically disadvantaged people. So do they have transportation to get to the places to get, proper nutrition, and their financial hardships? Can they afford groceries each week? How much money do they have? Are they on a limited income? All right, so when we are doing our assessment of these patients, we are going to want to identify patients who need to lose weight. So we're going to look at a couple different things. We're going to base it on their BMI, right? We're going to calculate their BMI. We're going to look at their cardiovascular risk factors. But we also have to look at the patient's readiness for behavior change. So for us, and our knowledge as healthcare providers, seeing what we've seen and what we've learned, we know what's best for the patient and how important it is for them to want to be ready for this, and we want them to engage in this changing behavior, but they might not be ready for it. I feel like everybody has to be ready before they're going to do something. They just can't do it for other people or because someone told them to do it. So we want to make sure they're ready for it, and we have to evaluate their readiness to lose weight, or it's not going to be successful. And then we always wanted to determine what the goals of treatment are. So for some people, it's all or nothing. They have a lot of willpower. Just get in there and do it. For other people, they want to start out slow. So, maybe we're going to have 3 meals that are this, or I'm going to slowly incorporate more vegetables into my diet. And you know what? At the end of the day, if the ultimate goal is that they lose weight and they do, then that method is perfectly fine. Spiritual and cultural considerations always. We have to understand the variety and selections are going to be unique to each person, and we have to respect those. We want to think about race. If they exercise, what type of exercise do they do? What kind of family gatherings they have. They might, if they haven't seen Grandma Wilma in 3 years and she makes great potato salad with lots of mayonnaise, it might be expected that when you see her, you eat Grandma's potato salad, because if not, it might be offensive to her. So there could always be that expectance to eat particular foods, especially within cultures as well. And different religious practices. And then again, the food ability, their access to food and food variations. So some nursing diagnoses that we see: imbalanced nutrition, more than the body requirements, that activity intolerance, ineffective therapeutic regimen management, and chronic low self-esteem related to being obese and not feeling good about yourself. So planning. So we want to educate our patients about a healthy diet. Like I said, a lot of patients don't realize what a healthy diet consists of. What is a normal portion? How much should we eat on a daily basis? Should we measure things? What kind of a food scale we should have? How important these things are. So we need to do a lot of education. We want to encourage our patients to weigh themselves weekly. We want to encourage them to keep a food diary so they can really look back and see exactly what they were eating. Sometimes when you're going through it during the day, it doesn't seem that terrible. But then when it starts to add up and you count your calories, it paints a completely different picture. We always want to encourage that they eat more fresh fruit and vegetables. And we want them to eat less fatty foods, and we want them to avoid those sugar-sweetened beverages, those empty calories. We want to discuss fat substitutes, so we can incorporate healthy fats. So we can use olive oil when we cook, avocados, things like that. We can use yogurts instead of sour cream, ricotta cheese instead of sour cream, or sometimes in cake mixes, we can put that in place of oil. We can use pureed fruits or vegetables, especially if we're having a hard time getting our littler kids to eat. We can puree it and put it in spaghetti sauce and things like that, and they don't even taste it. And we can use applesauce as a replacement for oil in different recipes. And then we want them to commit to some type of regular exercise, to start somewhere, even if it's just a walk 1 to 3 days a week to start for 30 minutes a day. It's a start. So their dietary regimen should be low calorie, nutrient altered. So we don't want them to have, it should not be high in sugar. It should be low in sodium. It should be low in fat, low in cholesterol, and high in fiber. Fiber helps keep you full longer. Some of our novelty diets that you'll see, I'm sure you've seen them everywhere. Some people do the keto. which is low carb and high fats. Some people do fasting. There's a variety of different diet things out there that people do. Interventions for weight loss, there are medications that can be given to help curb your appetite so that you take in less calories. If medically appropriate, there is bariatric surgery, but you do have to, it's quite a process to get that done. You have to be a certain, you have to be able to need to lose a certain amount of weight. I think it's usually like 100 pounds. And then you have to lose a percentage of that weight before you can have the surgery. So they want to know that you're committed. You have to prove to them that you've changed your lifestyle and your eating habits. And then we want to instill those comprehensive lifestyle treatments. So exercising 3 to 5 days a week, reading those food labels, planning your meals, eating at home, packing your lunch for work, that kind of stuff. Lifestyle treatments that we can see, again, that diet modification, decreasing our caloric intake, adding more fruits, adding more vegetables. Oh, sorry. More physical activity. And then behavior modification. So focusing on changing the client's eating and exercise behaviors, because this does become a behavior. They get used to sitting at night before bedtime and stop it, and having a certain snack. So there is a lot of behavior modification that goes into changing our diet. Stop it. Lay down. All right. So for patients that have to go the route of getting prescribed some type of a medication that will help with their appetite, this is only recommended for people who usually have a BMI greater than or equal to 30, or patients that have a BMI greater than or equal to 27, but also have other chronic health conditions, so diabetes, hypertension, things like that. It would be appropriate for people with a waist circumference of greater than 35 for women and 40 inches for men. Would also be candidates for pharmacotherapy if they also had comorbidities present. So this is a list of some of the medications that we could prescribe. Orlistat works to reduce the absorption of dietary fats. So the side effects are that it's that the fat is going to be excreted in the stool. So usually the stools are very liquidy, greasy, and loose. So I don't know if you guys remember, many years ago they had chips that had olein in it that were supposedly a lot healthier because they were made with this oil. What everybody that ate them had diarrhea and really oily stools. So that's kind of like the same principle. Then we have Belfwick, which works by enhancing the feeling of satiety, although some patients report a decrease in appetite or a decrease in craving. So it helps you feel satisfied longer. Then we have phentermine. This medication has been around for a long time, or topiramate. Together, they produce an appetite suppressant, helps you keep suppress your appetite so you're not hungry, you don't take in as many calories. Then we have Victoza, which impairs your appetite and increases your satiety. And then you have our naltrexone bupropion combination, which leads to decreased appetite and fewer cravings. So drugs that we use to help with obesity, they are central nervous system stimulants, some of them. It's very easy to develop a tolerance to these medications even after a few weeks. So often the doses have to be increased. So they have to be regulated by your physician. Some of these do run the risk of potential for abuse. And then they do come with some side effects. So increased heart rate and blood pressure, dry mouth. Some patients report having trouble sleeping, agitation, nausea, diarrhea, and then constipation. So bariatric surgery is one of the most effective treatments that we currently have for severe obesity. It is appropriate for clients who have a BMI of 35 to 39.9, and who have major comorbidities, so diabetes, hypertension, hyperlipidemia, things like that. Bariatric surgery works by restricting the stomach's capacity. It creates a malabsorption of nutrients and calories, and or you can have a variety of both. So one or the other, or a variety of both. There's a couple different methods. They have a lot of different, I feel like they're always adding new ways to do this. So currently you can do restrictive bariatric surgery, which is gastric banding, and adjustable banding. So I think the adjustable banding is where they go in and it's not a permanent thing. It can be, your stomach can go back to the normal size after a certain amount of time. Then you have the restrictive malabsorptive. So that's the gastric bypass, where they actually go in and they bypass an area of the stomach, and then you have a biliopancreatic diversion. You can read more about these in your book. They go into a little bit more detail. So let's see. This is your laparoscopic adjustable gastric banding. So if you can see, this right here is the stomach. They go right here and they put, it looks like this band on it. It's an inflatable silicone band. So now your stomach went from being this big to actually being this big. So if you look at the capacity, it's only 10 to 15 mLs. That is the smallest amount. I mean, you guys have measured 15 mLs in a medicine cup in lab. It's not a lot. So it is that pouch is created with a limited outlet between the pouch and the main section of the stomach. And it looks like, I think in this type, this is actually reversible. Let's see. Yes. So it's adjustable. So, and you have an inflatable band, which encircles that uppermost stomach, and then it's buckled. The small pouch can contain 15 to 30 cc's. And the outlet diameter can be adjusted by inflating or deflating a small bladder inside the belt through a subcutaneous reservoir. So it is adjustable. This is the vertical banded. You can see how it goes off here to the stomach, a little bit more of a capacity, 15 to 20 mLs. This is the bypass. So this is where they cut off a portion of the stomach, and you only have this right here is your usable part, that 20 to 30 mLs, and then it goes right here into the large intestine. Usually the nutritional concern that you have with this is dumping syndrome, because it doesn't go through all the processes to get broken down like it normally would, because you're bypassing that whole route and it just dumps right into that large intestine. So this is just, this was in your book. This is a picture before the biliopancreatic diversion with duodenal switch surgery, and then this is after. So you can see how your food would have to go down and go everywhere. And here it doesn't. It just goes, it cuts it off and it goes right to particular part of your duodenum. And then you have your sleeve gastrectomy. So this takes out, it actually removes about 80% of the stomach on long ways, and it results in a small pouch resembling a sleeve, which is why they call it a sleeve gastrotomy. You still have your pyloric sphincter in your stomach and your intestines. So the pathway of the digestion of your food is still intact and it's not altered. Because you remove most of the stomach, you are going to see that the hormones in your stomach, those hormone levels induce satiety. So you're going to feel fuller, faster, and longer. It's going to inhibit the amount of food that you can take in because you get fuller quicker. It will also increase your insulin sensitivity, and you're going to have a slower gastric emptying. because you have such a smaller area to deal with. We just talked about that. So some of the complications that we see, we can obviously have bleeding, always the potential for blood clots. You could see bowel obstructions or leaks or anastomosis, which is where it leaks. You could see an infection, especially where those staples are. Sometimes it doesn't work and they have to go back in. Like I've seen it with the bands where the band comes loose for some reason and they have to go in and redo it again. A lot of patients report nausea, especially in the beginning. Dumping syndrome, changes in bowel habits, obviously, especially depending on the type they've had, and then nutritional deficiencies, because if you're taking it in and it's automatically going to the large intestine and it's dumping out, you're really not absorbing it and getting those nutrients that you need. So for patients that get this bariatric surgery, there's always this post-surgical time that we do things a little bit differently. So at first they're on just a clear liquid diet for usually like the first, I don't know, it's different for each type of surgery, like the first week, sometimes maybe just 3 days, depending. The progression starts with small quantities of sugar-free clear liquids. These people have to go through a lot of education. For months, they're taught exactly what they're going to have to eat. They're taught how to count calories, what type of foods, what kind of nutrients are in which foods, what they can tolerate, what they can't. And then you start to advance their diet as tolerated. So you can go from liquids to full liquids. And then once you're tolerating that, then you can move to pureed foods. And then after you tolerate that, usually within 5 to 6 weeks after surgery, then you can start incorporating that regular diet. But then, of course, there's always those nutrition therapy guidelines that you want to talk about with your patients. And then weight maintenance after loss. So keeping the weight off is even harder than losing it. Diets that lead to weight loss are not necessarily effective for maintaining weight loss. I feel like people that do the keto diet, it's kind of some people can do it and they don't have any problems with it and they can do it for a long period of time. There's more of a percentage of people that can only do it for a small amount of time because it's hard to incorporate that into your lifestyle. And then when they start eating those carbohydrates again, they see this huge weight loss that comes back. The single best predictor of who will be successful at maintaining weight is how long someone has kept his or her weight off. So evaluation. So we want to follow up with our patients. We want to talk to them about their weight loss. Are they incorporating any exercise? How often are they weighing themselves? They should be telling us what modifications they're making, how their diets have changed, what behavior patterns they've changed. Are they eating with family members at night? Do they cook for their family members now and they're all on a healthier diet? Do they make themselves eat breakfast in the morning so that they don't eat more at lunch? Things like that. And then they should also be able to identify a good support system. Let me see what's on this slide. Malnutrition. All right. So when we talk about a patient that has malnutrition, sometimes we are monitoring to make sure that they don't get malnutrition. So we're looking for risk factors. And then sometimes we are looking to see if they suffer from malnutrition when they come in. So this could be an elderly person who lives alone. It could be someone who's in a nursing home, someone who had a stroke. We're always looking to identify malnutrition in our patients. It can occur from not having an adequate nutrient intake. We know that. If they have issues with absorption and excretion, we can see issues there. And then if they are losing nutrients. So we talked about the patients who suffer from alcohol abuse. They're always deficient in vitamin B because their body needs that. So the prevalence of malnutrition among hospitalized adults is estimated at 30 to 50%. That's a large number of people. So 50% of the people in the hospital right now are going to suffer some type of malnutrition. That's not acceptable considering that it's preventable. The widespread cause of disease and mortality throughout the world is malnutrition. Malnutrition increases mortality and the incidence of complications in both medical and surgical patients. We know that we need that good protein diet to help to manage our comorbidities and to be able to heal if we've had surgeries and other issues. And malnutrition is much higher in long-term care facilities, where we might see 85% of the population that are malnourished. So sometimes it can be starvation related. So this occurs when food is not available due to environmental or social circumstances. So it might be that maybe Mrs. Jones doesn't drive anymore because she can't see. She doesn't have any family near her and she really can't get to the grocery store. Maybe she just had a hip replacement and she just can't drive right now and she's having trouble getting stuff over the next few weeks. Or maybe she has an eating disorder. And that would be something that would be starvation related, would be something that we caused ourselves. Anemia, bulimia, something like that. Patients might have some type of chronic disease that's causing them to have malnutrition. Or we could have an acute disease or an injury that could occur. Patients that have multi-trauma issues, major infections, any kind of critical issue, pneumonia, the flu, COVID, something like that, where they're really knocked down for a couple weeks and their nutrition just hasn't been where it needs to be. So this is a chart that you guys can look at in your free time. These are the characteristics that you want to assess for malnutrition. It looks at weight loss over a period of time, inadequate food and nutrition intake when compared with what they're required to have, loss of fat mass and muscle mass, any kind of fluid accumulation in the body, and then measurably diminished hand grip strength. So starvation is when our body breaks down fats into fatty acids and ketones to provide energy for our brain. The size of all body compartments is reduced as body fat and muscle proteins are going to be used to meet our energy needs instead. As our lean body mass starts to reduce, metabolically active tissue is going to be lost and energy expenditure is going to start to decrease. So our body then becomes considered, it's under stress. We're going to see hypermetabolism and catabolism. We're going to start to see cell and tissue breakdown. This is all part of the starvation mode. We're going to see protein calorie malnutrition. So signs and symptoms of that would be your patients are going to have abnormally dry and loose skin folds on your hands, in your abdomen, under your arms, on the side of your legs. You're going to see altered pigmentation of their hair and a severe loss of tissue from normal areas where we see fat deposits, so in their thighs or in their bottom. And then our lean body mass is going to be broken down because it's going to have to try and meet our nutritional needs. So risk factors would be age, definitely that older population, poverty, not being able to get the adequate amount of food, patients with mental health issues, again, depression, confusion, not being able to cook food or remember that they have to eat certain medications, substance abuse, so alcohol and drug abuse, they're not really thinking about eating. With alcoholics, they're drinking, all their calories are empty. Functional health problems, we're going to weight loss history if they've had bariatric surgery. Sometimes they don't get the proper nutrition that they need and their body can go into starvation mode. GI problems that affect a person's ability to take food in. And if a patient is unable to eat for 5 days or more, that's really when we start seeing these issues. And then any kind of chronic pain or illness, and then we know those acute problems, those acute illnesses. So we will see our general findings. Let me see. So we kind of talked about what their skin was going to look like. Gastrointestinal wise, they can be constipated or they could have diarrhea. They're musculoskeletal, they're going to be weak, limited strength, won't be able to ambulate like they normally would. Neurosensory, once it starts to affect our fluid and electrolyte balance, we might see some confusion. Certainly some cardiovascular issues with those electrolyte changes with potassium and sodium, things like that. If we have patients who have tube feeding complications, this can lead to malnutrition because, again, they're not getting the proper nutrition. We know patients that are malnutritioned will not have good wound healing. Those wounds are going to last a lot longer. They're going to be on antibiotics longer. It is going to increase their susceptibility to developing new infections. It's going to require longer hospitalizations for our patients because they're not healing. And then eventually, if it leads to an infection, it can also lead to death. All right. And that was nutrition. What questions do you have?